see a day that's not too far in the future that we will have patients that have a mutation and something will tell us if they actually will ever get pancreatic cancer or some other associated cancer. And we will cull the field in terms of the number of people that we're following. But your point is exactly right. This is a huge burden on the system right now.
I had a few questions. Sorry, more than one. My name is Suraj Tejasvi. I'm one of the GI doctors. I work in Austin. I had a question regarding the approach to cancer screening using blood-based versus stool-based. And if you think about blood-based, you assume that the DNA fragments are entering the lymphovascular system to be detected. And so, by definition, you're assuming some of it is submucosal already, as opposed to mucosal. Whereas if it's a stool-based test, you're assuming it could be mucosal, which is shedding and you're picking it up. So that seems to be a fundamental difference where if you do a blood-based test, you're more likely to detect something at a later stage than a stool-based test, number one. Number two is, if these blood-based tests are actually picking up markers from advanced adenomas, how is it pathophysiologically possible that it's entering the bloodstream and you're picking it up? Thirdly, can you do any of the blood-based tests that you're doing, like Real-Seq, as on stool? I think I'll stop there. I have a few more questions.
Who wants to start? Dr. Tomasetti?
Yes. So, you want to start? Okay. So, yeah, that's a lot of questions. So, but good questions. Let me try to answer, the best I can. Some of the questions you're asking, we don't have a full answer, right? So I'll start from the last, which is yes, we could use these technologies. We could use these technologies on stool. Okay, the concept is the same. One of the reasons why we are not is because our current understanding is that there are limitations in the uptake of this one is not really working.
Yeah.
So maybe
Try this.
Yeah. Because of the limitations in the uptake, and apparently, many people don't like to do that. And I'm not saying that therefore we should abandon stool-based approaches. I'm just saying there is obviously a part of the population that, as of today at least, is not going to use it, right? And so no matter how good it is, if you don't use it, it's useless. So having said that, and then for the other questions, which are about, how does the signal, how do you get the signal, submucosal or, well, my answer is, again, we don't have the full answer, and I'll tell you one thing that could be interesting right now, but first of all, I want to say, at the end of the day, the answer is whatever, if the test is effectively in full, in test set. Michelle talked about, training, validation, and testing. And by the way, I was really impressed, Michelle, because almost everyone inverts validation and testing. So you are like a true AI person.
I learned that at the heels of this gentleman and another oncologist at Michigan.
So when you do a completely independent set, and you pick up the cases, then you pick up the cases, right? So we may wonder how biologically that exactly works, but if you pick them up, it means that you were able to find the true signal, okay? So that's kind of my general answer to that. That's maybe a practical answer. One thing of interest is, I didn't mention in my talk, is that an important source of cell-free DNA, it's provided not just from the tumor cells, they're dying and being shed, but also from immune system cells, so white blood cells, they are fighting that tumor or cancer. And that's a very important thing to remember. And we published a paper, I didn't have a slide here, in Cancer Discovery, you can look at that. So I think part of, those answers are also related to things like that. Steve.
You're asking great questions, which are based on both pathophysiology as well as the application of the way in which we can use these technologies. And the one thing that I'd just like to consider for the way in which we apply these tests in a clinical setting is clinical decision making is based on prior probabilities and posterior probabilities. And of the technologies that we've heard about so far and discussed today, we really haven't addressed the idea that risk stratification can make a huge difference in understanding what the influence is going to be on the outcome of the test. For example, if you're offering a test that's either a stool-based test or a blood-based test to somebody who's had 10 polyps or 4 sessile serrated adenomas, the way in which you're going to estimate the probability could in fact be modified by that prior information. So I think over time, as we get more information that's going to be allowed to be used for inputs into this, and I'd love to get Cristian's thoughts about this because he's the mathematician who knows exactly how to do this. But I think as the technologies continue to advance and we can incorporate clinical information to essentially inform the likelihood of those outcomes, it's going to be even more helpful. Most MSET testings right now are not done in high-risk populations. NCI just funded a pilot study to be able to introduce these in high-risk populations. So we'll see.
I actually want to add. Let me add one more thing since what Steve said, and in fact I'll connect with what Michelle was saying before, her vision for the future, which I fully agree. I see the same one day. I think, and this goes also back to the question by Dr. Idos. I think that one thing that we currently are completely missing in terms of information for this prior probabilities and risk is actually the mutational speed in an organ, and in fact across organs in an individual. We today cannot measure healthy organs mutational loads. Okay, I can tell you this is about to change, and of course, first will be scientific papers, and then will come all the evaluations that will make this reversible, and and all of that. But this is about to change, and I think that is the future, because both for MSET, where you may not want to still screen everyone, but you want to identify those that who should take that test, as well in settings like Dr. Idos was mentioning, right? So these patients have these mutations, but are they going to progress? Are they going to get pancreatic cancer, for example? I think a very key ingredient is how fast the DNA in these people are mutating, right? It's not the whole answer, but it's a major piece of the answer, right? The higher the speed, the more the probability. It's exactly what Steve was mentioning. We are close to get there, which is the most exciting thing. I call that project my baby, in fact.
Yeah, Stephen Lin from MD Anderson. It's a quick question. I really enjoyed all the multi-cancer detection tests and the implications clinically to patients and also to physicians. I know it's not a problem now. We have, most tests are very specific, right? I think that's once you have it, there's cancer. Sensitivity is, at least for early case detection, is still difficult. But there's also potential clinical implications when the test becomes too sensitive, right? So there is let's say you have a stage 1, but it's undetectable from any kind of diagnostics that you can do conventionally. What do you do in that setting? Let's say there's a lead time of months, maybe in a year, when the cancer starts developing, at the multicellular level, but then impossible to detect with current conventional testing. What do you do in that setting? I don't know, I just wanted to hear your thoughts.
As you.
I'm not. I think Cristian might actually be the better person.
Microphone toss.
I don't think anyone. First of all, it's a great question.
It is.
And it's a big challenge, and I don't think we have an answer. The truth is, I don't think we have a full answer. I would say, I would still want to know. You know what I mean? And whatever, whether it is okay, let's retest in 6 months, right? The fact that you have something positive, if it's a true positive, right? I think you were talking about a true positive case where you just still cannot detect it on screening. Obviously, it's a piece of information. And let me also mention, this goes back to the false positive issue and all that. I think we are moving to a future where people will have to become more comfortable with talking about probability and risk and not having clear answers and having the stress of you need to come back. We don't, no one is saying you have cancer, but say because we need a CT scan or whatever else is the follow-up. We have to move in that space, if we really want to make the progress that these technologies can bring.
Let me just add one other.
Here, rather than doing this whole
Yeah, you're
whole-
right. It's
I'm getting tired of sitting between the two of you already. Here you go.
I'd just like to ask a question. How many people here are actively leading or take advantage of a multi-cancer early detection clinical program? Okay, it's actually an increasing number. And Jewel, I'd just like to ask you to comment about how at Mayo you've begun to approach those individuals who are undergoing testing and responding to those results, even when it's not initiated in our own practice.
That's a great question, Steve. And so many of these clinics are starting up. So at Mayo, we have done actually about 4,000 Galleri tests up to now. Primarily, as you said, they're not being done in the average population or general population screening. These are done in concierge populations. We have executive medicine clinics, but again, across 3 large destination medical centers we have in Minnesota, Arizona, and Florida. We've done 4,000 Galleri tests. We published that data recently. We found a test positivity about 1.4%, which fits with what the data has been. Between 1 and 2% of Galleri tests will have a positive result with a tissue of origin signal. And then at Mayo, when we follow those patients through diagnostic workup, we have about a 70% true positive. So higher than what's been reported by Galleri and other companies, which range around 40 to 50%. I think that is partly because at Mayo, the workup is very thorough. They're having longitudinal follow-up, so even if the first set of PET CT or imaging is negative, they're having another one done 3 months or 6 months later. If a colonoscopy or endoscopy is negative, we're ensuring the bowel prep is adequate or repeating it. So I think it's the thoroughness of that. So the next step of this is that Mayo's just opened as of last month a tri-site, meaning across all 3 campuses, a multi-cancer detection clinic. The goal of which isn't really to offer MCD testing, as that would overwhelm our volume or provider bandwidth, but really to allow for expedited workup of test positive patients. So you would call a 1-800 number essentially. You would be seen by one of our internal medicine specialists who have a focus in MCD technology across our campuses, and we essentially will have diagnostic workup completed in 96 hours. And if you still have a negative workup after a positive test, we will bring you to one of our tumor boards for that tissue of origin signal to discuss what are the next steps. So, and this is really coming to many medical centers. I know City of Hope, MD Anderson, Dana-Farber, Cleveland Clinic are opening similar strategies, because this testing is going to happen in the market, whether we fully approve it or not. People will get it, and we need to have an ability to act on it when available.
I don't know if this is working. Oh, kind of. There we go. I think all those are amazing insights, and actually it's an excellent question, because it really bears into the component of that is a lot of kind of healthcare dollars and effort to treat this very small amount of population. And again, for 50 to 70% kind of false positive, true positive, that's a lot of follow-up in terms of time and accuracy. So if I'm thinking of my time at the Mayo, if we go from time extension, so if we think that we can doing things in 96 hours, in Canada, you would be lucky if that could happen at best within a couple of weeks, at most likely within a couple of months, to see multiple specialists get multiple tests, regardless of whether the indication was we see cancer on an image or multi-cancer early detection test being positive. And so acknowledging that time component, that's time of person not knowing false positive versus true positive, so the anxiety living component, which arguably definitely is a more of a nuanced and a more of a realistic expectation for patients these days, but also acknowledging the amount of cost that is essentially instilling into, again, from a public standpoint and an individual standpoint, quite high. From what I could read about on the websites for all the individual testing kits and the studies that have been published, if someone's test is positive, we can't find a source after CT, imaging, et cetera, all the cancer signals have been investigated, we repeat tests in 6 months, and then an undefined amount of time, we have a higher amount of screening. Well, is that higher amount of screening all of the existing population-based screening? Do we use the Galleri test or whatever test on a shorter interval? Each round is another $1,000. Each round of pan screening, PET scans, is many thousands of dollars. And so we've now further kind of consolidated that, even though the results are super promising and great, even within on an individual a la carte component, that is a lot of money that we don't necessarily know, is it truly impacting outcomes yet? And so I think that right now we still are within the clinical trial sphere, and exactly, it's in market, there's nothing we can do about it. And so there currently has to be these programs set up to deal with it and to see how it's gonna be borne out in real life. And I think that everything that the Mayo and a lot of these expert centers are doing is exactly correct. You know, that's how you should be doing all these things, that's how we want to respond. It's just one of the ones where in many other places, we can't respond that way.
And I'm going to add to that. If you look at the UK ovarian cancer study, this really is, I think, the linchpin of my concern with MCD technology. So in that study, they took several 100,000 women in the United Kingdom who were screened for ovarian cancer, and they had 3 options. There was usual standard of care, so only if you're symptomatic did you get a screening for a diagnostic workup for ovarian cancer. Second group got a CA-125, and a third group got both a pelvic ultrasound and CA-125 done. And what they found was there was a stage shifting. What does stage shifting mean? It means we detected more earlier stage ovarian cancers in the group that got the blood marker or the combination ultrasound and blood marker. This was before MCD, so this is using an older fashioned protein marker, but similar concept at least. So you found more earlier stage cancers, well, that would be a win, right? In theory, we made earlier stage ovarian cancer diagnosis. But when they followed that population out for mortality, there was no difference in survival, whether you were detected with ovarian cancer at stage 1, 2, or 3, or more distant ovarian cancer. And so that is the one concern that MCD hasn't really talked about in the industry. Are we just stage shifting and not making a change in survival? They are asking the FDA and other regulatory authorities to approve trial design on stage shifting, with the assumption that by shifting the stage of diagnosis to earlier cancer, we will inevitably make a difference in survival. That may be true in certain cancers, and it may not be true in other cancers.
You're right.
Yeah.
So I fully, I fully agree with the concern. Actually, the variant, I think there is evidence that stage shift brought some lifespan increase, but overall, okay, this also doesn't really work. This,
The only one.
But, okay, but overall, what I wanted to say about this point, which is absolutely a fair point. Okay, we don't even have really for MSED stage shift evidence yet. The studies are coming now, so you cannot imagine. Obviously, we don't have any data on increased lifespan thanks to MSED. My point is, does that mean that then, therefore, we shouldn't use that? Of course, I think we should, definitely in clinical trial type of settings. And from my point of view, and I think the field of there is a network, EDRN, NIH. I think the group has agreed that stage shift can be a good proxy, at least to start using it outside clinical trials. And I understand that we don't have the full evidence for it. I agree. On the other side, the other option is we wait 15, 20 years, right? And I personally think that if you told me today, do you want to have your stage shifted? even though we don't have evidence that is going to make a difference for your lifespan, I would say, please tell me right now.
Perfect. Let's take 2 more questions. This is actually wonderful. I had cases made, but this is actually better. So we'll save our case presentations for later in the session.
Hi, man. Thanks. Great talks. My name is Vero Loza from Greenville, South Carolina. 2 questions. One is, we've talked about when we start screening for things like pancreatic cancer. When do you stop? And I think that's something that people don't really talk about. But then you have to go through MRIs in the U.S. for say 15 years, 20 years, and there's a burden of that. At what point do you actually say, all right, you know what, you're 70, we don't have the tools yet for predicting this probability of you developing cancer, concretely at least. When do you actually stop? So that's question 1. And question 2 is, I see a lot of patients for ATM or BRCA gene mutations, patients who've had breast cancer or other cancers that are associated with these gene mutations, who come because now they're worried about pancreatic cancer. So they've already had one cancer from a said gene. There's a higher risk for pancreatic cancer with those genes, but they have no family history of pancreatic cancer. What do you guys do with those types of patients?
I'm going to keep my answers very brief, and anybody else let me know if they want to chime in as well. The question about stopping screening, I think the obvious ones are the patients that are no longer fit to undergo surgery, because what are you going to do with that, right? And if I didn't convince you today that surgery is paramount when you have early stage disease, you weren't paying attention. So that's a kind of like a cutoff there. But keep in mind that especially in pancreatic cancer, age is a risk factor, right? It's the unchangeable risk factor. So if you have a fit patient that's 70 years old, I'm not going to stop screening you at that point. And I don't know what other people would say. The issue about gene mutations and no family history of pancreatic cancer, that's a patient-doctor conversation, right? That's where shared decision-making becomes key and pivotal, because, in certain gene mutations like BRCA1, there probably isn't good enough data, honestly. Deanna will tell us about that, to do screening in those patients. And so if you can convince the patient that the harms of longitudinal follow-up and the costs associated with those outweigh those potential benefits, that's a win. But I think even in many of the other mutations, like in the graph that I showed you, the table that I showed you, the risk is high enough that even without a family history, you would screen.
Maybe I'll add in one thing I've learned from our breast radiologists, who obviously see a lot of our BRCA, ATM patients and offer advanced breast imaging with MRI in that population, that they have a concern that the IV gadolinium that's being used in the breast imaging does over time collect in the brain. They don't know if that correlates with a negative outcome, but again, something that should be there in your brain over 10, 20 years of annual screening may not be a good thing. Do you guys talk about that in pancreatic screening at all?
Yeah, I have patients that actually come in and ask me about that, that have that concern. So a well-educated patient is going to have that concern.
Oh.
Hi, thank you for the wonderful talks. Mohit Girotra from Swedish Medical Center in Seattle. Dr. Anderson, a couple of comments and a few questions, please. Actually, Viral asked a part of my question already, so let me actually just continue with the same question. He presented the high-risk gene mutation scenarios. I often get patients in my clinic who have a single family member, first-degree relative with pancreatic cancer. Of course they are worried. Of course they do not fall into the typical CAPS2 criteria. So that is a difficult conversation which I always get into. You have to balance healthcare dollars as well as patient attributes and their sensitivity towards this diagnosis in their family.
I use that. I tell them, this is my background, this is what I'm looking at, and yeah, I see pancreatic cancer every day of my life. I tell patients that they have cancer every day. And I wouldn't do it for me. I wouldn't do surveillance and screening in me. So if I'm making that decision personally for myself, I wouldn't make anything less for you.
And in patients, those who you are following for a while, getting these yearly MRIs alternating with the EUS, you don't stop them if they are still healthy candidates for surgery, but do you vary the interval at any point? For pancreatic cysts, for example, yes, you can spread the intervals out, but do you do them for HRIs as well? I don't think there is any data which exists on that front.
Yeah, I don't think that there's any data on spreading out intervals, and right now the guidelines, none of the guidelines that I know of are there.
know, that allow for spaced out intervals for that. So, I mean, we need the other 3 doctors sitting at this table to come up with an answer for that one.
I will say a first degree relative of pancreatic cancer, at very least would qualify them for genetic testing. So that is NCCN guidelines now. And so if that person then was identified to have ATM,
That's what I do.
BRCA,
Discuss
so that
these
would be.
facts with them, and then establish them with genetic clinic. That's the most I do,
But
but
not
I
if the
disappoint
proband
them. I
didn't
know.
have a mutation, right?
No, exactly.
Like my dad was tested, he had
Yeah.
nothing.
Right, correct.
Thank you so much.
I was going to say just a quick addition for Evan. There was a paper, I can't remember who published off the top of my head, about switching your intervals. Not so much switching the intervals, but switching your modalities to something that might be more likely to be covered by insurance, at least in Canadian standpoint. So I do EUS. We have EUS available on our site, but again, it's only major centers that have it. And so we'd now move to EUS at baseline and then MRI until a change. There is a study showing that kind of EUS MRI alternating is no different than EUS baseline, 3 years of MRI, go back to EUS, then 3 years of MRI. And so basically creating a new pattern that may be more amenable to insurance coverage. So if you have patients that can't go forward with just the kind of static basic recommendation, it might be an easier way to get
It's
insurance
actually
coverage.
the other way around. Getting imaging is probably harder to get
I agree.
approved.
Oh,
You can
that's
always
right.
make a case for EUS with upper GI symptoms. So there are other ways of doing things, but for MRI, you've got to document it.
He's right.
Thank you.
Hi Vivek, just a quick comment on the spacing of intervals. As part of the PRECEDE consortium, we see every month 3 or 4 cancers from around, now there are 35 countries in the consortium. The problem is not with the normal pancreas or the pancreas with minimal change. You can go out with that patient, a couple of years, 3 years. The problem is we still don't know, and as this distinguished panel has clearly demonstrated, there is a patient that will transform on you without notice and without any currently known risk factor or imaging modality that you have at your disposal. So that's what we see every month. The best people in the world with the best technologies are still finding interval cancer. So my only cautionary note to those people who want to extend intervals is that as of now, the guidance is to do alternate imaging every year in the appropriately selected high-risk individual. Please don't deviate from that. So case selection is very important, but once you've selected the case, stick to what is currently known, because if one of those patients transforms on you, you will have to have some justification, unless, like Dr. Anderson said, you have done a shared decision-making discussion in the clinic, which is very nuanced, very, very customized, that in this particular patient, for this reason, we are going to deviate from the guidelines at this time.
And then document.
And document that. I was going to follow up. So, but there is a patient that transforms on you without notice and without any of us having any ability to predict that. So be very, very, very aware of that. Thank you.
Perfect. We're going to end the session. Hand it back to Dr. Kachami.